Doctors Kwako and Brumder Ross, thanks so much for joining me on the show today.
Glad to be here. Thanks for having me.
Pleasure, Aaron. Delightful to be here.
Yeah, well, so I was very excited to do this podcast in large part because I post a lot on social media, on LinkedIn in particular. And what I found in the past was that whenever I would post about alcohol, people would have this very muted response compared to other substances. And so coming into Alcohol Awareness Month, I kind of approached it with a bit of like bated breath, like, let's give this a go. I'm going to go all in on Alcohol Awareness Month and we'll see what happens. But actually there was a resounding response this time around. Folks were very interested. They were very concerned in a way that was surprising in a way, but also very heartening, because I think this is an issue that almost paradoxically flies under the radar, given the magnitude of the issue that's going on right now with alcohol-related health problems in our country, and how little attention I feel like it gets when we really ought to be talking about it more. And so that disconnect is actually where I was hoping to start today. So, and I'm going to send the first question here to you, Laura. So in terms of the public's understanding, what are the biggest areas of misconceptions about alcohol use and health that you've seen?
Yeah, that's a great question, Aaron. I think one of the most enduring misconceptions is that alcohol is good for your health, that there are amounts of alcohol consumption that are beneficial for heart health or that help relieve stress in a positive way. And what we know now from the research is that there is no amount of alcohol that's actively good for your health. There are a lot of studies recently showing increases in risk for example, breast cancer or other forms of cancer at relatively low levels of alcohol consumption. So 1 drink a day. But most of the public in this country, and I would say probably across the world, is not aware of those associations, again, between relatively what we might consider low levels of alcohol consumption and impacts on long-term health.
Yes, so quick follow-up on that, and I've definitely seen that research that's come out very consistently showing that idea that we can drink some small amount and it can actually be helpful has been disproven now. In terms of low risk behaviors, do we have any guidelines in particular? And I know obviously individual levels of risk for folks, that changes that equation a little bit, but are there generalized ideas of what lower risk drinking is, even if it's not actually healthy?
Yeah. So generally, the less the better. The USDA guidelines for alcohol consumption are no more than 1 standard drink of alcohol per day for women. So that's no more than 7 per week. And I want to emphasize it's 1 drink for women on a given day. It's not 7 drinks on average or total across the week. And for men, it's 2 drinks per day. So that would be no more than 14 drinks per week. That's certainly that's not what we would recommend necessarily people drink. One of the changes that we've seen more recently is, information coming out from the World Health Organization about the harms of alcohol, but also changes in some parts of the world in terms of their recommended drinking limits. So, for example, Canada, fairly recently issued a new guidance on alcohol and health, and they said that it was 2 standard drinks or less per week in which people were likely to avoid alcohol-related harm. So that's a lot lower than those USDA guidelines recommend. And I really appreciate you raising the point as well about individual risk factors. So with a few exceptions, we don't really know an individual's specific risks of harm from alcohol, right? So, almost certainly some people may be able to consume more alcohol and experience less harm than others. But again, with a few exceptions, we don't really know what those are.
Mm-hmm. Right. Whether or not it has to do with genetics or other, factors around that change those levels of risk for progression. Can I toss the question over to you as well, Thekla? Are there any thoughts you have on that or misconceptions? Yeah.
Yeah. Well, I'm going to bring up changes that happen in a woman's life. So around menopause and perimenopause completely changes the way that alcohol feels in our body. And women can start to notice the different effects of just one drink, a half a drink, a small amount of alcohol. It brings us back to the beginning of the discussion when Dr. Kwako said, no amount of alcohol is good for us or beneficial, right? It's not adding to us in any beneficial way. So I think the guidelines are lower than people expect. And I think that's just a wake up call for all of us that haven't been empowered yet in our society to really say, hey, is this serving as our overall health in any way? And if not, then how can we be more conscious? And really, to Dr. Kwako's point, any bit less is better. And we all probably know that and feel that in our bodies, despite the differences among genetics and health conditions and overall factors.
Yeah, I think that's a really good point. Oh, go ahead, Laura.
I just wanted to add, if I may, there was one additional, you'd asked about enduring misconceptions. And I don't know that this is a misconception so much as a misunderstanding for a slight difference. But a lack of knowledge about what a standard drink of alcohol is, right? NIAAA has this great graphic on our website that shows what a standard drink of alcohol is. 12 ounces of beer at 5% alcohol by volume, 5 ounces of wine at 12% alcohol by volume, and about 1.5 ounces of distilled spirits. And most people don't know that. And that includes most healthcare professionals, right? And so not having that shared understanding of what a standard drink is really makes it difficult for people to understand the impacts of alcohol on their health. It can make it difficult for healthcare professionals to advise them, because someone might say they're having, for example, 1 glass of wine a night. Depending on the size of the glass and the concentration of alcohol in the ABV in that specific wine, that could be more like 3. That's a big difference. That's a big difference.
Yeah, and it's almost always pointed up, right? It's not like it's less than you think. It's usually like, oh, there's the way that the Long Island iced tea is mixed has more shots than you think, or the martini, so on and so forth. Thekla, go ahead.
Laura and I, when we're teaching healthcare professionals, it's a part of our role to empower healthcare professionals to have a conversation about alcohol use with patients. And we bring this glass that an entire bottle of wine, Aaron, fits in 1 glass. So when somebody says to my doc, oh, but I'm only having 1 glass of wine per night, but it's like there are 5 standard drinks, right? If they're 12 ounces or 12% ABV in that bottle, right? Less, even 4 if it's 14%. So it's really getting curious, I think, about our society. And we know that in some of our restaurants, right, the margarita is huge when we're looking at in terms of the size of the drink. So standard drink, we used to put up the standard drink size charts that Dr. Kwako mentioned on the NIAAA Core Resource website. We used to put them up all over the exam rooms at Kaiser Permanente, and patients loved talking about them. They couldn't believe it, and they were empowered, and it was so fun to compare the different drinks. So I think it's really about empowerment, both our healthcare professionals and all of us in society.
Totally agree with you there. I think, Dr. Kwako, you brought up the point that people oftentimes aren't aware of what the guidelines actually are, or even sometimes that when you look at the relationship to harm, that it comes a lot more quickly, at least statistically speaking, than you think. And I think that idea of empowerment through information is so key. That's part of why I post so very frequently on LinkedIn, is that I think that if people understand the information, they can make those health-related decisions for themselves with the information that they need. And I think that's where things get tricky sometimes when it comes to recommendations, is that people, because I remember hearing there was a lot of, grumbling, commotion when Canada released their guidelines. I think when we started talking about how, when risk starts to creep up, statistically speaking, like we're not telling people what to do. We're just informing folks about risk. And I think that's a very important distinction. I don't know if you guys on the inside have any thoughts about that.
Yeah, I completely agree with you. So we at NIAAA, we're not recommending a return to prohibition, right? We're not telling people specifically what to do. But it is critically important to us that the public are aware of the the risks of alcohol consumption, even at relatively low levels. So people will make the choices that they make, but we want them to know what those risks are and to be informed. And that counts for healthcare professionals and the entire, American public at large.
Yeah.
Well said. Can I make a parallel? So we empower our youth and we empower our community when talking about the food. We used to call it the food pyramid. I think it's called the food plate now. But we're not telling people, not to eat certain things. We're saying, be mindful, be aware of the balance and how much you're having of this thing or that thing, right? And now we're talking about being aware of sugar and how much sugar is in things, right? So it's about this awareness, and we haven't empowered, as you said, Erin, we haven't empowered the public with awareness and the standard guidelines. And that's what we're here to do, is empower people.
Mm-hmm. Well, so along those lines, I want to toss it back over to you, Laura. So in terms of the health issues that NIAAA is focusing on right now, I know I saw an article recently looking at projected increase in issues related to hepatic function, liver disease, that at least made some national ripples when that article came out. But from an NIAAA perspective, whether or not it has to do with messaging campaigns or whether it has to do with research, what's on your radar right now as your big foci for informing the public?
Yep. So one of the big ones right now is the impact of alcohol, specifically on women's health. So we know that women process alcohol, metabolize alcohol differently than men. They are at increased risks for harms from alcohol at lower levels of consumption than are men. And these risks really run the gamut. In particular, though, I do want to mention liver health, which you brought up. We're seeing pretty specific and alarming increases in rates of alcohol-associated liver disease, particularly among young women. So women under the age of 50, increases in hospital admissions for alcohol-associated liver disease. And I will say we have grantees at NIAAA who are hepatologists, work with patients, seeing increases in rates of liver transplantation and requirement of liver transplantation for young women in their 30s and 40s. And that's really alarming. That's really alarming to us at NIAAA. Yeah. In addition to, broadly the impact of alcohol on women's health. So it's not just liver disease. It's increased risk for alcohol-associated blackout, heart disease, cognitive deficits, certain cancers. We know that alcohol impacts what we consider mental health, right? Anxiety, depression, post-traumatic stress disorder. And so those are areas of specific focus. And I'll also say too, so we just a few weeks ago released our strategic plan for the next 5 years. And one of the big areas of focus is the impact of alcohol on whole person health. So while we are very interested and very concerned with specific impacts of alcohol, for example, on liver disease, we're also, situating alcohol in the broader whole person context. Alcohol affects every organ system in the body. There are over 200 health conditions that are worsened by alcohol consumption. And some of them are, things like hypertension and diabetes, which are extremely common. So, we're really wanting to take this broad approach to how alcohol impacts health. And I think that goes along with what Dr. Brumder Ross was saying about empowerment. So that if people are aware that alcohol can affect all aspects of functioning, they may make different choices when it comes to their alcohol consumption.
Mm-hmm. Marvelous. Well, thank you for all the work that you're doing there. Thekla, go ahead.
Yeah, I just wanted to say, in addition to what Dr. Kwako was saying around women in health, we actually know too that we're not consistently screening and intervening the same way with women as we are with men. So we know that women are less likely than men to get a brief intervention. So having this conversation with their provider around heavy episodic use or alcohol use disorder, in Black and Latina women are even less likely than men to get a brief intervention. And we know that those with lower socioeconomic status have 1.5 to 2 times greater risk of death from alcohol attributable causes. So we know that our systems are, structurally violent and inconsistent. But this is why at NIAAA, we really promote this we ask everyone approach. Like, we really have to ask everyone consistently and routinely about alcohol use, and really, again, address alcohol, both men and women, right, in a way that is promoting this whole health approach that Dr. Kwako was talking about.
Yeah. Well, and actually, I think that's a great bridge to a question I was planning on asking you a little bit later, Dr. Brumder Ross. Well, I'll stick with you for a second about the medical side of this and how to better optimize the relationship between patients and providers. Because something that I know I've seen, so I'm a clinical psychologist in private practice. I work with folks primarily with addiction, and alcohol, of course, being the most common amongst those. And I've also have a history in healthcare systems where I was the director over an addiction service line for a 3-hospital system. And I've seen from both sides, there's this discomfort in having that conversation between patients and providers. Patients oftentimes feel like their physician will judge them, or that, there's still that layer of stigma on top of it where they feel like they can't talk about their alcohol use. They don't view it as a health concern. They view it as something else. And from the provider side as well, I think there's either a discomfort, potentially not knowing what to do if someone says that they're having a problem or a concern, or just feeling like it's awkward to poke around that beyond perhaps just like some automated audit screen that someone would do in their intake paperwork, and then you don't necessarily follow up about it anyway. So I'm wondering, you mentioned screening, and I think that's so important, because if we don't ask questions, if we don't have positive screens, if we don't detect a problem, it's very difficult to treat it. How can we start to look at that, really, in my opinion, very fractured relationship between patients and providers, and start to mend that gap so that women and men can receive better care?
Such a great question, and I'm super passionate about it, so I'm glad that you asked. Dr. Kwako and I were just at the American Medical Student Association conference, and what did we hear from medical students? We heard they are hungry. They want to know how to have a conversation with their patients about alcohol. Freudian slip. It's interesting. It's across every medical subspecialty. This isn't just folks who are coming in saying, I want to be a primary care physician. This was every type of medical subspecialty coming in saying, we barely get any training. If we do, it's the outdated screening tool. How do we have the conversation? Oh, and maybe not just also with our patients, but maybe with our family members and friends and loved ones. I mean, people were lining up at the door. How do I have this conversation in an empowered way? We're all behaviorists. We're all psychologists here. We know that knowledge, skills, and confidence help empower us to have the conversation in a comfortable way. We haven't empowered our healthcare professionals in this way. I had the incredible privilege of training a large majority of providers at Kaiser Permanente across all 8 markets in screening and briefly intervening for alcohol. And I can tell you that they were all, no matter where they were in their career, equally as hungry for information to have this conversation in an empowering way. The stigma that exists in society impacts our healthcare professionals too. And they get a very small amount, we all know that, of training around alcohol and drugs within their medical training. But I will say the kind of conversation we had with these medical students was also about curiosity. Like, what does the alcohol mean for the patient? Where is it in their lives? I heard one of the medical students say, I really want to just sit alongside this patient and have a conversation that helps them feel like I'm not judging them and empowering them. So we gave them a 3-step process, a part of the core resource on alcohol on our NIAAA website. It's really easy to use. We have 3 CMEs to train medical healthcare professionals. We have a 3-step process: ask, assist, advise. Everyone walked out of this 45-minute session knowing, I know how to ask, I know how to assist, I know how to advise in an evidence-based way. So we can do that, and we can empower folks. Also, back to Dr. Kwako's point about a whole person health. We talk about stigma, time constraints, right? All these things being barriers in asking the questions and briefly intervening. One of the things I observed at Kaiser Permanente in rolling out screening and brief intervention is when we train doctors how to weave in the alcohol conversation to the overall health conversation, to the presenting medical condition. So maybe I'm coming in with hypertension, or maybe I'm coming in with diabetes. I can't address those if I'm a healthcare professional without talking about alcohol. So how do we weave in the dialogue? I'm concerned that your drinking is exacerbating your hypertension, your diabetes, and I'd like to help you. I'd like to partner with you. Can we talk about how to cut down or stop, depending on where they are, right? If they're a heavy episodic drinker or if they have alcohol use disorder. So really empowering our providers to have the conversation in a way that can weave into all of their other conversations and not add extra time and extra burden, right? Because they don't have time. They don't have more time to be doing more, right? So it's how do we weave it into the overall health conversation? So just to quickly summarize, I think it's increasing education and training, which we at NIAAA are really passionate about. And as I said, there's just so many free resources available on our core resource website. Implementing routine, as you said, Erin, standardized screening. So having that in the medical record alongside the smoking question, the blood pressure question. At Kaiser, we call it alcohol is a vital sign. So, right, it's alongside all the other vital signs. And then again, back to this empowering people that evidence-based treatment is there. And I know we're going to get to this talking about medications for alcohol use disorder, and that we know behavioral therapies work. We know that it works. We have all these resources to empower folks in. So we need to make sure we get those to the folks who need it.
That was an incredibly thorough and fantastic answer. Thank you, Thekla. Dr. Kwako, do you have any thoughts to add to that in terms of...
Yeah, just one, because as you said, it was an incredibly comprehensive and thoughtful response. And that is, in the context that alcohol is widely used in our society, it is legal. Many healthcare professionals may use alcohol, right? And so I think we have to be explicit and open about the fact that it can be very uncomfortable for healthcare professionals as experts, right, in health, to be asking their patients about their alcohol consumption if these healthcare professionals haven't thought about their own alcohol consumption, right? And so there may be concern that, well, what if I find out that someone is, or drinking more alcohol than I think is healthy, but then maybe I'm drinking more alcohol than may actually be healthy. And so again, we raise these issues to empower people, raise it from a place of no judgment, but really wanting providers to be open and to be curious, and also to be explicit that you're probably going to have to think about your own relationship with alcohol at some point. And that will make those conversations, these screening conversations, these questions that you'll have with your patients, they will almost certainly make those conversations a lot easier.
Yeah, no, I think we're in a period of national reflection in a way. I feel like I've seen like the dry January movement gain steam year after year. I actually, a couple of podcasts ago, did one that I found very fascinating with Dr. Molly Bodring out of Stanford, who's doing research on non-alcoholic beverages and what's going on in that side of things. And we're seeing an uptick there as well. And I think a lot of it comes from this very health conscious harm reduction approach, not necessarily of folks who are mired in like a really intense alcohol use disorder, but folks who are using alcohol, but thinking like, wait a second, like this does, even if they can't articulate, this affects 200 different potential problems. They're aware that it's very caustic to the body in a lot of ways, and they're trying to reduce exposure. Thekla, did you want to add something?
Yeah, I just want to say, so this group of medical students that are just so empowering for us to hear them talk about it and be so hungry about wanting to talk about alcohol use. They were so honest and vulnerable about alcohol in medical school culture and how we need to look at it and explore it and examine it, right? It's a high stress environment. There's a lot of pressure. It's a way that our society normalizes letting off steam, right? And I think Dr. Kwako and I have this agreement that if they go away having drinks together with awareness of, is this a standard drink? Are we being poured a standard drink? How many drinks? Let's keep each other accountable. Like if that is the result of the training, then we've done our job. We've created this curiosity, this awareness, this exploration among our future physicians that has them looking inward so that they can partner in a healthy way with their patients.
Yeah. Well, and let's use that as a bridge then to my next question. And Laura, I'll pass it back to you. I remember, so I've seen a couple of articles recently that really made an impact on me in terms of the numbers about just the very low percentage of folks who are being prescribed FDA approved medications for alcohol use disorder, of which we have 3. And then there's actually even more that some physicians will prescribe off label. But the number, I believe, was 2%, 1 out of 50 patients who's hospitalized for an alcohol-related medical condition leaves with one of the medications that's been FDA approved to treat that condition. I think it was 1% for those who make it to the emergency department. And we could probably spend a whole episode just talking about some issues around, ED treatment of folks coming in for alcohol-related conditions. But just if we want to keep it to the medicine side for a second and the prescribing side, that seems like such a low rate when we talk about a chronic health condition where we have possible medications to help, that people are just not receiving it. And in my opinion as well, this is more anecdotal, not even being informed that they exist, not necessarily that they're rejecting it as, if offered, but they're not even aware that they would leave not knowing that these options are there. And so I just wanted to get your take. Why is that number so tremendously low, and what can and should we do about it?
Yeah. Yeah, that number is staggeringly low. And there are a lot of reasons. I think there are three, when you look at the research, there's three sort of main or overarching reasons for this. So first, and I think this ties back to consideration of stigma and sort of the normalization of alcohol in our culture, that really gets down to treatment philosophy, which is that many healthcare professionals, with the exception of, for example, physicians who are board certified in addiction medicine or addiction psychiatry, many healthcare professionals don't think that medications are an effective way to treat alcohol use disorder, right? So that, has been found in healthcare professionals who are prescribers and those who are not prescribers. These healthcare professionals, psychologists, social workers, addiction counselors, all of these disciplines who work very closely with folks who have alcohol use disorder or who may be poised to discuss some of these concerns. So when there's this belief and this philosophy that, medications just don't work for treating alcohol use disorder, they're not even going to raise them. They're not necessarily even going to look and see what those medications are. And then, associated with that is stigma, and I really think that treatment philosophy still is grounded in the stigma that we see against addiction and against alcohol addiction specifically. So that's the first, treatment philosophy and stigma. So there's also this lack of knowledge about the FDA-approved medications for alcohol use disorder, and specifically concern about the complexity of prescribing these medications and their efficacy. So, healthcare professionals are not aware that it's relatively easy to prescribe naltrexone. You can do that in a primary care setting. The side effect profile is relatively low. You don't need a specific waiver for prescribing it. This can be done. Same with the camprosate and with disulfiram or antabuse, the third FDA-approved medication. And then third, there are very real barriers to accessing medications. So those can be barriers related to geographic locations. So we know that, rural parts of the country have there's less availability of the medications to treat AUD. There are socioeconomic barriers. So that in more impoverished parts of the country, again, there's just less of the medications available. And also there may be some formulary restrictions and availability in pharmacies. So, even if a prescriber wanted to provide medication to treat AUD, it could potentially be very, very hard for their patient to find it easily, right? And so those are just some of the three big reasons. And I think obviously there's some interplay there. In terms of what we can do about it, I think it's things like this. It's raising awareness. It's letting healthcare professionals know that there are these three medications out there. They are easy to prescribe. They've been around for many years. Their safety is typically well documented. But also educating people that they're effective. That people who take naltrexone, for example, which is available in an oral pill form or injectable form, people often report that it's very helpful in reducing their cravings, especially early in recovery. It can be one of those really vital tools in helping people feel better, and to not return to alcohol consumption. So yeah, there's a lot to it. There's a lot to it, and we obviously have a very long way to go. But I'm hopeful that through conversations like this, and also really through talking with medical students, as Thekla said, we were recently presenting at the American Medical Students Association. These are the providers of the future, right? Yeah. And so making it very clear to them, hey, these are available. You can prescribe them to your patients. You can even teach up and talk to your attendings about them, right? Yeah. So really kind of thinking long term, and how can we get these medications into the hands of prescribers and into the hands of patients?
And Thekla, I'd like to get your opinion in a second, although I want to just reflect. So I completely agree with you about education, because when you mention treatment philosophy, the first thing that pops into my head is, well, where does that philosophy come from? Like if we're not actually learning about it in school, if we're not being taught, like how is it being formed? And I think that's where that stigma can start to root, or, if it's more just passed down from perhaps others who might not have come at it from an evidence-based perspective. But I know that it's challenging too, because I'm thinking back to the beginning of the healthcare response to the opioid epidemic. And I remember being I forget the exact situation. I think it was a state of Illinois, like an Illinois Medical Society meeting, something like that. But we were advocating for, well, let's try to include some education about opioid prescribing and treatment into some like required CME every year. And there was tremendous pushback, actually, because, well, then everyone will want to get their thing in there. Like, well, so you want to get in there. Well, someone else wants to get in there, too. And who's to say that your issue is more important than this other person's issue? And it's a very slippery slope, and there's no room in the curriculum, and there's no room in CME for current providers for everybody. So we're not going to take you. And I think eventually that relaxed when the crisis got bad enough. And, hopefully things don't have to get so, even worse than they already are. But I completely agree that education is critical. This is this question of how do we prioritize, I think.
Yeah.
But Thekla, did you want to add something as well?
Dr. Kwako did such a beautiful job in describing that. And I just also want to say, with the education and training, all of the eyes got bigger and wider, and people just don't know, right? And so I think it's really about also saying, one of the things we heard from the medical students is what I mentioned before, no matter what medical subspecialty, right, they were still interested in medications for alcohol use disorder. I mean, similar to how we're seeing psychotropics being prescribed in all of these different areas, right? It's about empowering and training. So it's back to that. Just want to say, historically, we know that traditional recovery-based models like AA, right, were hesitant in the past around prescribing medications or encouraging folks to use medications while they're in recovery. I know a lot of folks in the recovery community, both through my own clinical practices in the past and through family members. And I think there's a lot of education happening in those communities as well around the importance of medication when it comes to overall health and well-being.
Yeah, really, really good points. And I'm going to pivot us here. I'm mindful we're down to our last 10 to 15 minutes or so. So we got to pick up the pace a tiny bit. Although I feel like we could probably talk about this all day. Maybe I should come join you guys at NIAAA or something. But anyway, continuing on. So in terms of talking about it and creating dialogue, I started the show by mentioning that it seems like we don't talk about alcohol nearly as much as we probably should. It's not on the front page of newspapers. I know that something that I was saying in the beginning of the month, Alcohol Awareness Month, I was saying we're all aware that alcohol is out there, but what we're not aware of is the normalization. There's almost like alcohol blindness, where we're not seeing that, in terms of alcohol-related death, this is just as big of an issue, if not even larger than, say, opioids, which isn't to compare, which one is the worse problem. They're both very important to address, but I think that in terms of the amount of attention that alcohol gets, versus how much damage alcohol is doing, and from a public health standpoint, it's a lot less. And I think we've kind of poked around the edges of this issue in some of the other comments about people maybe being reflective of their own use about it, or just in terms of historical perspective. But I'd love to get both of your thoughts, but we'll stick with you, Dr. Brumder Ross, here to start. How do we start to raise awareness of this in a way that will stick, particularly if it's uncomfortable for folks to think about? Because we all know, again, as psychologists, we tend to slide away from things that make us uncomfortable emotionally.
Such a great question. Let's just start with the normalization, right? I mean, we have gotten to the place where we have alcohol at baby showers at 10 a.m. in the morning, and it's just normal, like that's just a normal, and assumed that in mother-infant groups, that there's mothers in wine shirts, right? And paraphernalia around that. So we just need to acknowledge the deep rootedness of how alcohol is ingrained in our culture and has been considered, quote unquote, socially acceptable. I think that we've talked about stigma, but I think we each have a role to play in stigma, and I think it's about the language we use. I, as an addiction specialist, right, I was trained, I did an entire postdoc in addiction medicine. I worked in addiction medicine for over a decade. And I was trained using really stigmatizing language around alcoholic and alcoholism. And I am making a conscious effort to know that my words matter. And when I say a person with alcohol use disorder in my community, with my healthcare professional colleague friends and with my neighbors, that makes a difference. Now, I know in the rooms of recovery, people strongly identify by saying I'm an alcoholic. I'm not here to tell somebody what they can and cannot use in terms of what works for them. But I know that if we empower our community with destigmatizing language, that will start to spread into the lexicon and into marketing and communications and advertisements and posters. And it's, Erin, it's sort of back to a point you made earlier around, alcohol in the news and sort of how we're talking about it. I would just say that these comprehensive education campaigns, whether they happen like within the healthcare arena or in the public arena, and they need to be more present in collaboration with this work we're doing around, and that we at NIAAA are so passionate about in terms of empowering our healthcare professionals. I would lastly just say there is, and Dr. Kwako can mention it, there's a resource with NIAAA around specific populations that are at greater risk, like college students. And there's a resource that I think we talked about, Dr. Kwako, earlier around promoting more awareness among populations that are at greater risk. And so I know NIAAA is really invested in doing some of that, similar to the women's health conversation that we had earlier.
I think this is probably going to be the longest show notes that I've ever done, because it'll just be this comprehensive list of resources, because you guys do put together so many useful ones. Dr. Kwako, did you have anything to add on that point?
Yeah, just briefly. I'll say, I think it's important to meet people where they are in their alcohol consumption. And that's sort of one of the underlying tenets of motivational interviewing and motivational enhancement therapy, which is one of the evidence-based behavioral health approaches, right? Which is that, if someone doesn't know what a standard drink is, let's educate them. Let's empower them. If they don't know how many drinks a week they're having, let's ask them. If they don't know what the health impacts of alcohol are, let's tell them. But let's meet people where they are, and also provide a bridge to potential treatment and letting them know there are a wide variety of treatment options available. Part of the reason that people may be hesitant to talk about alcohol, whether it's a healthcare professional or a patient is hesitant to bring it up, is that they don't realize how many effective options there are for treatment, right? So if they're thinking there's only Alcoholics Anonymous or, air quotes, rehab, and I don't want that, I can't be away from my family for giving them a time. There are so many other options that they can take advantage of. And so I think really providing that information, again, which is empowering, and also hopeful and inspiring, that if you want to cut back on your alcohol use, you can do it, and we can help you do that.
Yeah, well, that is a perfect bridge. Let me stick with you, Laura, for a second, to the last point I wanted to get to before we end for the day, which is about how do folks find help? Because this is obviously a very challenging and fraught landscape, I think, between, people. There's so much money flowing around, not just on the addiction development side, perhaps, but also the addiction recovery side in terms of, body brokers, practically, people just trying to get into residential treatment centers, the advertising for certain places not necessarily affecting the reality. Even I think a colleague of mine brought to my attention, there was a whole Medicaid, like human trafficking scam, essentially, to Arizona, I believe it was, where they were trafficking Native peoples down there to fake sober homes and things. So it's so hard for folks to find quality care around addiction. So if someone wants to change their relationship to alcohol, whether or not it has to do with an alcohol use disorder, or even just someone who's noticing, hey, I think I'm leaning on this a little bit too heavily. I'm having, if the recommendation is 2 or less per night for a male, and someone's finding themselves at 4 or something on average, where should someone go? How can they find quality help, quality care to achieve their goals?
Yeah. I am delighted to tell you about 2 specific resources that NIAAA has. These are websites. So the first one is mostly for those folks who are, in the space that you just mentioned. And this website is called Rethinking Drinking. So it is literally for people who are doing just that, who are saying, I enjoy a drink often at dinner, but I'm noticing that my sleep is not as good. Is this alcohol? Could it be causing it? So if you go to the Rethinking Drinking website at NIAAA, there's specific information on how much alcohol is too much. There's calculators there so that you can see how much alcohol you're consuming. There's information if you're thinking about a change, sort of what are the considerations that you might want to have. There are specific tools, worksheets that can help you evaluate your drinking, decide whether and how to make a change. So it's really this wealth of knowledge. And again, this is the Rethinking Drinking website that NIAAA has. Now, for people who are looking for quality treatment for alcohol-related problems, we have another website that is the Alcohol Treatment Navigator. And the banner on that is find your way to quality alcohol treatment. So we recognize that it can often be very difficult for many reasons for people to do just that. And there's information here about what to know about alcohol treatment, specifically how to find quality alcohol treatment. What are the questions that you should ask a potential provider, right? And what are the answers that you should be listening for? So this is very specific, very explicit information that people or their loved ones or healthcare professionals can use. There's information on how to find support through the process, frequently asked questions, toolkits, and there's also a specific section on that website for healthcare professionals specifically. So again, these are two websites that NIAAA has had for a number of years that are very robust. They provide evidence-based information and specific concrete tools for people who are first wanting to maybe rethink their relationship with alcohol and then also find their way to quality alcohol treatment.
Yeah. Well, I'd love to get your opinion as well, Thekla, before we finish up. But I just want to echo that empowering people to make changes, like when they're at that point where they've got the motivation to make a change, running into a wall, like bouncing off the front door of change is the last thing that we want. And so being able to have those tools online accessible, they'll be in the show notes. But please check them out, folks. They're fantastic. But Thekla, please go ahead.
I just want to plug one of the resources that is on those two websites that Laura talked about. It's called Options for People Who Are Thinking About Their Drinking. It's an evidence-based tool from some of my colleagues at Kaiser Washington, Dr. Kathy Bradley and team. And I have printed this out, Erin. I have given it out. I have sent it in more text messages than I can possibly imagine because loved ones, family members come to me and say, where do I go? And what websites do I use? Those two websites that Laura talked about. Honestly, I give them out every time. I go through the navigator with folks to help them find evidence-based treatment. And I say, where does the conversation start? It starts with options for people who are thinking about their drinking. It's non-judgmental. It asks the question in an evidence-based way using a lot of those motivational interviewing techniques, open-ended questions and empowering questions that we were talking about. And it's something you can do alongside of a loved one, a peer, a family member, a friend, right? And I would also just be remiss to say that one of the greatest assets of our society is the amount of recovery-based groups that there are and that exist both online, in person, in all of our communities, both for loved ones, so Al-Anon, for folks who are concerned about their loved one, and then AA, Smart Recovery. They have a lot of different programs and resources and different subsets of group, Women's in Recovery. So just for people who are further along on the continuum of use, those are also free resources for folks, in addition to the evidence-based care resources and websites that Dr. Kwako talked about from NIAAA.
Yeah, well, I'm going to wrap us up here just for sake of time, but thank you so much for that fantastic response. And I think what I take away from this, perhaps more than anything else, is how it can be complicated and there's a lot of options, but it also can be individualized and is not hard to do. Whether or not you're working with a professional, whether or not you go to one of your websites and you use the tools that are there, it can help take what seems like an overwhelming amount of options in some cases, or even sometimes feeling like you're being funneled into options you don't like, and realize that actually it can be broader, it can be narrower, and you don't have to navigate that terrain on your own, particularly if you're feeling vulnerable because you're struggling with a substance use disorder of some sort. So, I wish we could go 2 hours or 3 hours, but we cannot, alas. But thank you so much, Drs. Brumder Ross, Dr. Kwako. Thank you so much for coming on the show today. Really appreciate it. Do you have any final thoughts before we sign off for the morning?
I just want to echo your message of hope and inspiration that recovery is possible. Treatment is available. People can do this. It often does seem overwhelming, but there's a lot of good information out there. There are a lot of people who are there to help you. So please, if you're someone who is concerned about your alcohol consumption, looking to find treatment, please take advantage of some of these resources that we have available. Thanks for the opportunity. Really appreciate it.
And Erin, I just want to thank you for being a leader in our community and speaking out and asking questions and getting us curious and sending around articles and saying, what do people think about this? And how do we feel about this? It's that sort of open dialogue that you've created in your fellowship and in our addiction community that I think is really, really, really important. So we're just honored to be here today and really thank you for asking such great questions.
It's incredibly kind. Thank you. Thank you.